Olá, pessoal. Meu nome é Rodrigo Munhoz, sou oncologista clínico e eu estou aqui no Oncologia Brasil com o intuito de falar um pouquinho sobre o cenário desafiador que se apresenta nesse momento em função da pandemia pelo coronavírus. Naturalmente, isso vai ter um impacto direto, e já vem tendo um impacto direto na vida de todos nós, mas surgem muitas dúvidas acerca de como adaptar a rotina do paciente oncológico, como continuar prestando atendimento aos pacientes que necessitam, mas sem expô-los em compensação ao risco desnecessário. E para que a gente consiga estruturar planos de ação de forma eficaz, nada mais adequado do que aprender com quem já passou por isso um pouco antes e continua lidando com o problema. E para isso nós contamos com o professor Paolo Acerto, do Instituto Nacional di Tumori, em Nápoles, que vai compartilhar algumas experiências e responder algumas perguntas específicas sobre essa interseção entre a pandemia por coronavírus e o cuidado do paciente oncológico. So, Professor Paolo, it's really a pleasure and an honor to have you here with us. We really intend to make a very fruitful video answering some questions regarding how to adapt this pandemic and how can we best still see our patients and provide therapy, but keeping everybody safe. So, I believe the first question is, the pandemic's had a major impact in all of our lives, but what were the routines that you adopted in your oncology center in order to face this pandemic? What were the changes in flows and algorithms in order to keep the patient safe, but still be able to provide good care?
So first of all, thank you for this invitation. It's a really pleasure for me, of course, to stay here with all of you and try to discuss some important issues in our field. And if you have also time, you know that I'm at the moment busy with a trial, the use of tocilizumab in the COVID-19 pneumonia. Having said that, you stated really clear that the most important things at the moment are to keep everybody safe. And this is, of course, the first thing that we should consider at the moment in our clinical practice. So what does it mean? This means mainly to avoid the crowded area, because this, of course, can increase the infection. And for cancer patients, this may be also really tricky, because we know that these kind of patients are the weak patients, and sometimes mainly the patients who are on treatment with chemotherapy. You know, there are also the immunodefense less responsive due to the treatment that we have. So what we did in order to try to increase the safety of all the people and patients who come here at the National Cancer Institute, we took some decision. For instance, look into surgery, and you know that one of my main interests is the melanoma. At the moment, we are postponing, all the wide excision from the low-risk melanoma, the in situ melanoma, the T1, T2, while for the T3 and T4, of course, we are still doing sentinel node biopsy. But in general, so we are preferring the high-risk condition to the low-risk condition. About the follow-up, consider that we have in our institute, the number of melanoma patients in follow-up is higher than 5,000. And in order still to avoid the crowd situation and to keep everybody safe, as you said, we are contacting the patients by phone. And the patients send us all the exams, the image, the CT scan, the US scan. So what they did, we are evaluating. And in case they need really clinical examination, we book the patients for the clinical examination immediately. For all the other patients, of course, we are postponing the clinical exam when the infection will be, the risk of infection will be lower, and we are managing every day the follow-up in such manner. So at the moment, all the patients who got some important news, a CT scan, the evidence of metastasis or something like this, or toxicity, of course, are the patients who are the priority, high priority to come in institute for the visit. About adjuvant, also we we took some action. You know that we have the possibility to wait for 3 months before to start from the surgical treatment before to start adjuvant. So if possible, we are trying to postpone the treatment until possible, as long as possible for the adjuvant, of course, no more than 3 months. We are preferring for the BRAF mutated the tablets, and because you know, the target therapy and immunotherapy at the moment is adjuvant, the efficacy is really similar. With the tablets, this may be better managed because patients take the tablets at home more than come here for the infusion, and in this manner we also reduce the possible risk of infection among the patients who are in the day hospital for the infusion. About schedule, we are preferring now the longer schedule. So this means for nivolumab every 4 weeks schedule, and for pembrolizumab every 6 weeks schedule. And in this manner also we are trying to reduce the number of patients who are on treatment in the same room. For the metastatic disease, we are continuing, of course, the treatment because these are particular patients, and no reason for postponing. But we are still trying to use the longer schedule of treatment with immunotherapy. We have a problem for the clinical trial because the majority of clinical trial, phase 1 clinical trial at the moment are on hold, because you know there is at the moment, due to the lockdown in Italy, it's not possible for some patients to come from the other region. In my region, yes, it's true that for a healthy problem they could come, but it's not easy because the number of the flights are reduced at this moment. This may make problematic also the coming from different region to here in Naples. So this is the reason, because the new enrollment at the moment are on hold. But about the patients who are in clinical trial at the moment are still these difficulties. What we are doing is try to manage according to the monitor, the visit and the exams, even in the places where these patients are, in order to try to maintain the quality of clinical trial and also the quality of the treatment and follow-up of these patients in clinical trial at high level, at good level. You know that one of the problem that was discussed is if anti-PD-1 checkpoint inhibitors can increase the risk of pneumonitis in the patients with COVID-19. At the moment, we are lucky because we don't have a lot of cases. We have 2 cases in 2 patients who were on treatment with anti-PD-1. Both one female, another male, got the infection after the 5th cycle. At the moment, we just stopped the infusion, stopped the treatment for safety reason, but the patients are good, still good, despite the infection, without any sign of pneumonitis. You know, we really don't know if treatment with checkpoint inhibitors may increase the risk of these pneumonitis. Someone described this possibility, but we don't believe. You know that there is also another particular aspect of this discussion, because the patients who are in treatment with checkpoint inhibitors could have also a better immunosurveillance. This could also reduce the viral replication. Anyway, probably we need more data, but at the moment we are considering the safety for such possible issue more for the adjuvant patients, not for the metastatic. And at the moment, we are not seeing really problem in the patients who are on treatment with checkpoint inhibitors. There is another important aspect in the follow-up of the patients in treatment with both checkpoint inhibitors and target therapy. You know that with the target therapy, the BRAF and trametinib, for instance, the fever is something really frequent. And in this period of the COVID-19 infection, the fever, it's something that we should look carefully. So in the patients where the fever continued despite the stop of the treatment, and if mainly there is also the cough and other sign, we require the nasal swab in order to avoid that there is an infection of COVID-19. Otherwise, if the fever goes down after the stop, of course, this is clearly related to the side effect for target therapy. In the patients who are in treatment with, and we got a couple of these, in treatment with checkpoint inhibitors, if there are the sign of pneumonitis, if no fever, in general, we start steroids. If there is also fever, we require the nasal swab still for avoiding the possibility for the patients that may be related to the infection of coronavirus. And because, in this case, of course, sometimes steroids may be, high dose steroids may be not so proper indicated. This is another reason of discussion. So this is in summary about what we are doing and the key question at this moment. Also that we are leading a national trial here with the use of tocilizumab in the patients with ARDS by COVID-19. So if you have time and if you want, I can also say something about this.
Definitely, that's a very, very important point. As of today, we're facing similar issues here in Brazil, also with clinical trials. Despite the risks of exposure, commuting is becoming more problematic to the patients, so bringing the patients to the cancer center is becoming more difficult. And we're also concerned about potential supply shortages in the near future, because most flights have been reduced. So bringing the medicines, bringing supplies may become problematic in the near future if we don't have a backup plan. And I'm confident that most sponsors and most pharmaceutical companies are coming up with plans to solve these challenges. But anyway, this is another topic to think about. So despite the number of cases, the information regarding cancer patients is very limited so far. So what was the experience, not only in the melanoma department, but for Instituto Nacional de Tumores as a whole? So what was the percent of patients that was affected, big numbers, small numbers? How are you dealing with those patients? And since you mentioned the clinical trial with tocilizumab, what are the specific approaches that you're adopting for cancer patients at this point?
So what, as I told you, we are lucky at the moment because we've seen the infection in a couple of patients, and also speaking with my colleague here at Cancer Institute, at the moment, the number of infected patients is not so high. I have to say that here in the south of Italy, the situation is, so we have an emergency, but it's not dramatic like in the north. In the north, the problem is higher. And probably there are also more cases, but I didn't hear from also this case from my colleague from North at the moment, still looking to the patient's treatment with checkpoint inhibitor, not only melanoma, but also the lung patients, that there is problems in increasing pneumonitis from COVID-19. In general, the cancer patients are weak patients, and mainly the patients with a bad performance status, the patients who are not so good, of course, the infection and the pneumonitis can get really problem in these patients. And that in China, what was seen is that there was a high incidence of death in this group of patients. At the moment, we cannot say this, but it doesn't seem at the moment that the group of cancer patients is the group with a higher mortality. It's more from the patients with the elderly patients with cardiological diseases. So this seems from the last report from our National Institute of Health. But that what we have seen, and this was an experience from still immunotherapy in the treatment with checkpoint inhibitor and CAR T-cell, that tocilizumab seems to be an important tool in the treatment of ARDS COVID-19 related. You know that the cytokine storm is the basis of the cytokine release syndrome from the CAR T cell and some treatment with bispecific antibody. And the cytokine storm is also the basis of the ARDS by COVID-19 pneumonia. Mainly IL-6 seems to be really related to the ARDS. When I discussed with some Chinese colleagues, because we had this idea to use tocilizumab in these patients, and this is also something under discussion in the management of the pneumonitis by checkpoint inhibitor resistant to steroids. They told, yes, this is a good idea. We tested this on 21 patients, and 20 patients out of 21 got an important recovery in 24-48 hours. For this reason, we started to use tocilizumab. At the moment, there is a national protocol. It's multi-center, open-label, single-arm, phase 2, with the 330 patients, started on the 19th of March. Just in order to give you an idea about how big is the problem in Italy, all the 330 patients were enrolled in 24 hours. And there is also an observational study, a parallel study, less restrictive, looking to the inclusion criteria. And at the moment, more than 1,500 of patients were enrolled in this observational trial. So more or less, about 3,000 of patients were treated with tocilizumab here in Italy. Not only tocilizumab, also other anti-IL-6 like sarilumab, because we have an emerging. What I can say you, because we are waiting for the clinical trial, the results from the clinical trial, the main endpoint is the 1-month mortality rate. And because the last patient was treated on 21st, 22nd March, for the end of April, early May, we will have the data about this clinical trial, and we'll see. But the feeling is that tocilizumab may work. The difference from the experience from the Chinese colleagues, the Chinese, they used the dosage of 400 milligrams, one shot, with possibility to repeat the dosage after 12 hours. But the Chinese population has a body mass index that is lower to the Western people. For this reason, we believe that because there is also this similarity with the CRS from the CAR T cell, to use the schedule that in general we use for the CAR T cell, CRS CAR T cell related, is 8 milligrams per kilograms with maximum dosage of 800 milligrams, with the possibility to repeat the dosage after 12 hours. We treated both intubated and not intubated patients, and as main inclusion criteria, we consider the oxygen saturation. If the oxygen saturation at rest is less or equal to 93%, or the PF ratio, that is a parameter that in general the intensive care specialists use, if this PF ratio is less than 300, this is the right moment to use tocilizumab. In general, the patients with higher baseline level of inflammatory parameter like IL-6, like LDH, ferritin, or like also CRP, that is really related to IL-6. These are the patients who can get an important improvement in 24-48 hours. So from the intubated patients, we treated before the clinical trial 18 patients. These are the data that I can say you. 7 patients were intubated. 4 of these patients recovered after 24-48 hours, were intubated. Now a couple of these are at home and they recover completely. About the 11 patients not in intensive care unit without mechanical ventilation, 8 out of these 11 got an important improvement after 24-48 hours, and 4 of these are at home at this moment. So it seems that these kind of patients not intubated, so before that the respiratory condition worsened, are the patients who got a better response, seems to be the best patient to treat it, and mainly if the level of IL-6 and the CRP are high. Anyway, we'll see from the clinical trial.
So these results are quite impressive. So your testimony is very helpful. And just to stress, then, this is a very important message. So you believe, based on your experience and the experience shared with the Chinese colleagues, perhaps the best moment to consider tocilizumab would be early on, during early signs of respiratory failure. So non-intubated patients, once the saturation becomes to decrease, that's perhaps the best time to consider tocilizumab. Is that correct?
Is this correct? And mainly if you have the inflammatory parameter high, the baseline, IL-6, CRP, LDH, ferritin high, this is a good moment to give the shot. And tocilizumab works as a one shot.
And you mentioned times to responses that can be as short as 24 hours or 48 hours for patients who are intubated. And what about these biomarkers? So how often are you performing them, and how are the curves of cytokines in those patients treated with tocilizumab? If you're able to share the data, of course.
So consider that the first sign, the first clinical sign that is a sign of an improvement and of action of the tocilizumab is the fall down of the fever. So in few hours, the fever go down, and this is good sign. IL-6 in the follow-up, it's not important because after the infusion of tocilizumab, you see a spike of IL-6. Why? Because the tocilizumab is able to bind the receptor and make free all the IL-6 that is bound to the receptor. So this means that all the IL-6 will be free in the serum, and this is the reason because you see an important increase. But this is not important, and for this reason, it's not useful in the follow-up. Why? More useful is the CRP, that in general, these patients with a good response become normal in 3 days. And so these are, in general, you have to follow the CRP and the ferritin more than the other parameters during the follow-up. And of course, you will see an improvement in the respiratory parameters very soon. And in general, also the CT scan after 5-6 days also show an improvement.
Good, thank you. So I believe we're running a little short on time. So Professor Acerto, if you had to suggest a general approach and perhaps some recommendations for us oncologists in Brazil, what would you suggest during these times, and how should we better prepare for the pandemics, and how to incorporate that into clinical practice, those possibilities of using tocilizumab, other specific agents during the pandemics?
Yes, first of all, as I told you, and as you also confirm me, it's important at this moment to optimize all our activities in order to make safer all our patients, in order to avoid the diffusion of the infection. In case of pneumonitis, if there is a pneumonitis, and if this the needs to treat these patients, at the moment, what we are doing in the patients who got pneumonitis but not so severe is to treat these patients with hydroxychloroquine and Calitra. You know, Calitra is an antiviral that is used against the HIV. You know, the results from the trial at this moment, from the Chinese trial, are not so excited, but better than nothing. The Calitra at least is something that could at least reduce the virus replication. This is a protocol that we are using at the moment. It's more a compromise that it's a really effective trial. But if we have the sign of the deterioration of the respiratory parameters, if you suspect that there is a cytokine storm, this is the right time for using the tocilizumab. If you want, Rodrigo, I can share with you the clinical protocol that we are using in order that all the Brazilian friends could also look to this, have an idea about which are the inclusion criteria. But I believe that anti-IL-6 are really important. What I also can say you, because, you know, the drug supply, as you said, it's really important. At the moment, we have 1,000 and 1,000 requests of tocilizumab. There is a problem, a delay in the drug supply. Used also the sub-Q of tocilizumab, but also the sarilumab, that is another anti-IL-6, and it seems that works like the intravenous compound. So anti-IL-6 really can be important tool. What can be additional drugs? At the moment in Italy, Novartis started an expanded access program. All of these, of course, are drugs that are at the moment available for free, with ruxolitinib. Ruxolitinib is a JAK1 and 2 inhibitor. It also has an effect on other cytokine. Are tablets, and also here it seems that may work in reducing the cytokine storm, probably a little bit early that the use of anti-IL-6. There is also the eculizumab, that is an antibody anti-complement 5, that also may be useful. There is another expanded access. There are some other JAK1 and 2 inhibitors, and also some to like receptor 7 and 8. So there are at the moment some different drugs, all active against the hyperactivation of the interferon gamma pathway, or the IL-6 or TNF-alpha. Although if you are not available the anti-IL-6, this could be still an option for the treatment of these patients. And then, there are some evidence that we should start very soon with plasmapheresis from patients who solved the problem. And if you are able to get plasma from these patients, you can administrate these in the patients at the moment in bad condition. It seems that this may work. And also, there are some experience with heparin. It seems that the heparin may be important to avoid, as first, the virus replication. And also, that one of the important condition that is probably the final condition, and this may be still mediated by IL-6, is the increase of thrombosis. And at the end, you can have also a picture of a DIC, and in the patients who are in intensive care unit, probably may be also important to give heparin. So all of these are more at the moment results of experience more than clinical trial. We need data, but this can help in case of emergency.
Fantastic, Professor Acerto. Those were very, very valuable insights. We thank you for your time and the opportunity. I believe that we're going to have a very, very good reception from our Brazilian audience, and that we're going to see in the near future those suggestions become a reality here in Brazil as well. So thank you so much once again.
Thank you for the kind invitation, and bye-bye to all the Brazilian friends.